Okay, everybody. Well, let's get started. I want to welcome everybody to the presentation today for Syphilis 101. My name is Tammy Bennett, and I'm a women's health nurse practitioner by training. And I have been teaching syphilis for probably the last 12 years. And I find it so interesting that once you learn about it, you can put this puzzle piece together and apply these principles to anybody that you see so that you can stage and follow the proper treatment guidelines by the CDC. So let's get started. If you ever have any questions, please feel free to put them in the chat or raise your hand using the Zoom controls, and we will stop and answer it as we go. Just a couple of acknowledgments. I do want to give Dr. Stephanie Taylor credit for teaching me how to put this puzzle piece together. This is based on her presentation with some additions and modifications. And also, we need the funding announcement that this was brought to you by the OPA grant that funds our clinical training center, and it's intended for informational purposes and does not constitute legal or medical advice or an endorsement of a specific product. And there will be some CE ability for you to, once you fill out your evaluation, you can request either CE for nursing or CME for medical. And it offers up to 2 hours for both. So our objectives today is going to be, we're going to learn how to do the stages of syphilis and what each stage criteria is. We're going to talk about the difference in the reverse and traditional screening algorithms. And then we're going to talk about titers and how we use those to determine if it's a new infection or an old, adequately treated infection. Again, this is me. I'm the Assistant Director of the Clinical Training Center. All right. Now that that's out of the way, let's talk about some statistics and trends. The state of the STDs in the United States, or STIs, in 2021 showed that we had 171,000 cases of syphilis, which was a 68% increase since 2017. But even back in 2021, we started seeing the rise of congenital syphilis, which was 185% increase since 2017. And then, move my cursor. So there, I'm just highlighting for you the need for why this training is so important and screening for syphilis. So the CDC put out some information about the rise and increase from 2013 in men, women, and then the total increase. As you can see, the rate in the women are increasing. And as they increase, you're also going to get women of reproductive health age that are having primary and secondary syphilis. Hence, when they get pregnant, they have the risk of um, developing or the fetus getting congenital syphilis. So until we get this under control here, then we're really not going to make a dent in congenital syphilis. We've got to decrease the primary and secondary in women. This is a video that shows you where we were in 2018 and the rapid increase in all counties really throughout the United States. It really affects most everywhere now. And hence you're on the call because you're one of the counties that has one of the highest case rates in 2022. So thank you for joining. Again, just like I was talking with regular primary and secondary syphilis, congenital is on the rise, and it's in 2021, you can see that we had 2,677 cases with a rate of 74.1 per 100,000 live births, which was a 24% increase from 2020 and a 702% increase from 2000. Very humbling. We do have some racial disparities when it comes to secondary syphilis. Congenital syphilis, you can see with the Alaska Native and American Indian, you have a very high case rate as compared with the Pacific Islander, Black, Latino, and white. This is the rate of congenital syphilis going up in most every state. So there's only a couple states that had no cases of this very preventable um, illness. So I think everybody should have their cell phone handy, I hope. But we're going to do a little bit of interaction throughout this next 2 hours that we're going to spend together. What I'd like for you to do is take out your cell phone, and if you will just take your camera and hover over the QR code, it should take you right into menti.com where you can answer. If you don't have access to that, then you can go to a web browser and go to menti.com and put in this code, and you can follow along as we go through. Okay. So did the statistics surprise you? Okay, so most of us on this call we know that our clinic was chosen for a reason. We've been dealing with syphilis for quite some time. So I'm glad to see that not everybody knew all of the statistics, even though a lot of you did. So thank you for that. In just end of last year, in the MMWR, CDC published the missed opportunities for preventing congenital syphilis. And so the impact is that congenital syphilis in the United States, we talked about, had increased 755% in the last 9 years. That means that we've had 3,761 cases with 231 stillbirths and 51 deaths. Imagine if 14 kindergarten classrooms just vanished. Would that not make, and have vanished every year, would that not make national news? Would that not make somebody just go crazy and flood our system with lots of revenue dollars to figure out where those children were going? Well, this is exactly what's happening with congenital syphilis. All of these kindergarten classrooms are now empty because the children did not make it. Humbling thought. In the missed opportunities, it did show that 87% of pregnant persons were not tested or not timely tested for syphilis. So testing is essential. And 39% did not receive adequate treatment during pregnancy. 11% had no documented treatment, and then 5.2%, the pregnancy infection was obtained. They got infected after the original testing, and they weren't retested later in the pregnancy. All right, so let's talk just a little bit about stages. And I want to see where we are pre-assessment as far as how comfortable are you with recognizing the stages. And you can use the same Mentimeter, and here is the QR code in order to do so. Let's see this pre-assessment, and then we're going to do this at the end and see how comfortable you are. This is all anonymous, so feel free to tell it like it is. All right, give it just another couple seconds. Great. Thank you for that information. We'll be able to compare that to after the presentation. Let's see how the impact this does. So I'm not sure if you've heard of the father of medicine, Dr. William Osler. He lived in the 18 and early 1900s, and he said, "He who knows syphilis knows medicine." Well, I am quite sure that I do not know everything there is to know about medicine, and therefore I'll probably never know everything there is to know about syphilis. But I'm going to share what I've learned, and hopefully that will help in your clinics. It is called the great imitator, and that's because so many times it is misdiagnosed or not seen as what it really is. It can be diagnosed as rectal cancer or penile cancer. Contact dermatitis has actually seen that, where they go to the dermatologist and they've given some Celestone and maybe some cream, and it goes away, and the patient thinks they're all good when no, actually they still do have symptoms. Um, Psoriasis and other things. And as we go through some of these pictures, then you'll be able to see how that could be easily misidentified if you're not really thinking about it. So the stages, you start with infection, where you are exposed to a sore, an ulcer, or something that's infectious. And then the primary ulcer starts with 3 weeks after you're exposed, then you develop a primary ulcer. And then after that primary ulcer, if it's not treated, it goes away on its own. So people may think, well, it may be missed. They may not even know they have the primary chancre or the ulcer. But if they do know it, it goes away on its own and they think, yay, well, don't have to worry about that. But then 1 to 3 months later, the infection disseminates throughout the bloodstream and you get more systemic effects. And that's secondary syphilis. That will go away on its own too if it's not treated, but you still have syphilis. And then 1 to 3 months later, it goes into the latency phase where there's no signs and symptoms of syphilis, and the only way you would pick it up is by blood testing. I do want to point out that neurosyphilis, otosyphilis, and ocular syphilis or congenital syphilis may occur at any stage. We used to think that it took a while for the bacteria to invade into the central nervous system, but we now know that that can actually occur at any stage. So we always want to be vigilant and asking about any visual changes, any hearing or ringing in the ears or things like that to make sure it's not invaded the central nervous system. Primary syphilis. Again, there's an incubation period of 3 to 90 days after exposure that they start having what we call a chancre, and this is just a classic picture of a chancre. What it is it starts as a erosion, but it's a clean base. It doesn't have turbulent drainage coming from it. And then you can see on the edges, you have kind of a rolled edge. That is a classic presentation. This is also very common. See, it's a clean base with a rolled edge. Now, every once in a while, usually they're singular, but you can have what we call kissing chancres. Like if the labia folds in on each other, you can get a chancre matching on the other side. I put this picture in because this is a person living with HIV, and when they get syphilis, sometimes it can invade tissues very deeply. So you can see where this on the surface, if you were looking at this, you might be thinking penile cancer or another type of diagnosis, but this is actually syphilis and in a person living with HIV. The reason why it goes unnoticed in 15 to 30% of the patients is because treponema pallidum has a numbing effect, believe it or not, on the tissues. So if you've got a numbing effect, even though this looks like it would be extremely painful, if this is near the rectum or inside the vagina on the cervix, which I have seen, it's very likely that it's going to go unnoticed. If it doesn't hurt, sometimes you don't know. But again, it will heal on its own in about 1 to 5 weeks, even without treatment. That doesn't mean you don't have syphilis. So then you break out into secondary syphilis. That's when the treponema pallidum bacteria goes systemic throughout the body. and you get a skin rash in about 90% of the cases where it's a maculopapular lesion that involves the palms of the hands and the soles of the feet. I was originally taught that if you ever see a rash on the palms of the hands and the soles of the feet, let that be your red light warning that it may be syphilis and we need to test for it. However, I have seen rashes that do not involve the hands and feet that are still syphilis. So um, it just varies really in the population. But if you ever do see it, think syphilis, but don't exclude it if it's not on the hands and the feet. Condyloma lata is different than genital warts. Condyloma lata, it looks like a wart, but it has a different appearance, and we're going to show that to you in a minute. Mucus patches, erosion, and canker sores, in your mouth, that can happen secondary, along with more constitutional symptoms. Like I said, it's going throughout the body, so you're going to get more generalized fever, malaise, anorexia, weight loss, which can also mimic HIV new infections. And then always be on the lookout for headache, meningitis type symptoms, eye and ear symptoms. Here's some pictures. One thing with condyloma lata that I want to show you is it can look like warts on original when you really look at it, but the difference between genital warts and condyloma lata is condyloma lata comes up very quickly. When I have seen this, I had a male patient that came in and said it just started 2 weeks ago, and I looked at how much it was, and I was like, surely you missed it. It's been having to grow for 2 years. But no, it was condyloma lata. As soon as we gave the bicillin, it was gone in 2 more weeks. It was done. The other difference is they are flesh colored, so kind of a pink colored, no matter what the skin tone is, and they're moist. Whereas the condyloma acuminata or genital warts is more of a dry uh, wart appearance. You can see nickel and dime lesions. If you saw this, what is something you might think of? Somebody want to put it in the chat? And then you can see alopecia, lymphadenopathy. If you saw this, a lot of people may be thinking ringworm or some type of psoriasis type thing. So you can see how it mimics other illnesses. All right, so let's talk about when they don't have any symptoms. There is an asymptomatic time called latent syphilis that's divided into two categories: early latent, late latent, and then you can have I don't know, syphilis of unknown origin or syphilis of unknown duration. We're going to talk about all three of those different types and how you categorize it into those sections. With latent, there's no signs of illness. So there's no chancre, there's no rash. The way to determine if it's early is that you have some way of knowing that they have got this infection within the last year. You're going to see me do this with my hands. Every time I do this, I want you to be thinking about 1 year time frame. We either have a negative serology test within the last year. That way we know, well, something's happened between that last test that was within a year and now because we have a positive test. We have a rising titer. You can see the old titer within that last year, and now it's risen fourfold. We know that they have been exposed to syphilis and got the infection within a year. If they were a contact to syphilis or they had an adolescent debut of sexual activity in the last 12 months. Now, syphilis of unknown duration or late latent, it's similar. Late latent, though, is where we have a serology result, but it was over 12 months ago. So we cannot guarantee it was within that 1 year time frame. It was over the year. Syphilis of unknown duration is that we don't have any past serology results. We don't have any serology results to compare it, whether it be over a year or under a year. Tertiary in this country is pretty rare, um, but it can happen, and it happened a lot more before we had the ability to treat with penicillin. It is a slow progressive disease. It happens over 10 to 30 years of having the infection, except when you have HIV. HIV, because you're immunocompromised, the syphilis infection can go much quicker throughout the body. 30 to 40% of people with untreated syphilis will progress to tertiary. So not everybody will have the final stage of tertiary. A gumma is a soft tumor-like growth containing these dead and swollen fiber-like tissues. You can see the gummas here. And to me, it looks like the bacteria is literally eating the flesh from the person. You can also have internal organ damage, including cardiovascular aortic aneurysm and aortic regurgitation. So not only does it do outward body damage, but it's also doing body damage inside, which can be very, very devastating and lead to death. Any questions so far? I don't see anyone unmuting, so we're going to keep on going to diagnostic methods. There are, yes, thank you. Please feel free to write it in the chat as well, and I can answer it as we go along. For serologic tests, there is two different types of tests. One is non-treponemal and one is treponemal. And then there's two different ways to screen. There's the traditional and the reverse. So I'm going to try to break this down to where it's easier to understand. There's a lot of alphabet soup whenever you're talking about syphilis and syphilis tests. And sometimes, especially if you work for a state health department or you're helping people with staging, you'll hear some of these alphabet soups and it might be something that you're not familiar with. So you might want to keep this slide just to make sure that you're talking about a treponemal test or a non-treponemal when somebody comes up with a new soup du jour. I put this slide in here because RPRs and VDRLs, while they both measure titers, they are not the same. And you always want to compare RPRs with RPRs and VDRLs with VDRLs. RPR is usually about one titer higher than the VDRL, so it's best to go ahead and titer out in your own facility, even if you have an RPR from, say, the blood bank or somebody. You want to go ahead and do your own titer in your own facility so that you can compare your facilities whenever you need to repeat that to make sure that your treatment worked. So I always like to know the why behind it and how it's done, and that helps me remember certain things. So the RPR, the way that that's done is they take a drop of the serum. You draw the blood, you spin it down, you get just the serum. You take a drop of serum and then a drop of the solution for that helps it clump together, and you mix it together. And if there's any clumping in this first wheel, then that's considered reactive and a 1-to-1. So then they take a drop of this solution, put it over here, and add another drop of their buffering solution. Mix it together. If it still clumps, that's considered a 1-to-2. Then they take it again and go over here, and they continue to do this process until it stops clumping. Now, as you can see, this is a manual process and it's open to interpretation. I may say it is a 1 to 16, whereas someone else would say, no, it really stopped clumping here, which is a 1 to 1, 1 to 2, 1 to 4. That's the way that goes. So it's very open interpretation. Now, with the VDRL, it's done the same way, but it's looked at under a microscope. So the microscope tells you you're able to see those clumps a little easier as you go through than just the wheel. The non-treponemal tests, the VDRL and the RPR, are looking for cardiolipin or lipodal antigens. And so there's other things that are other disease states that can cause these cardiolipin and less than particles to be in the bloodstream. Certain things like you've heard of lupus or pregnancy or IV drug use. Recent immunization, chronic liver disease. So there's other things that can cause these particles to be in your blood. So you can't just do an RPR or a VDRL and say, "Oh, you have syphilis." No, you may, and we need to do further testing. Now, the reason why a lot of people start with the serologic test is because it's cheap, it's easy, and then there is a reason to use these. Because it gives you that titer, you can monitor those titers to make sure that the treatment that you give is working. You want to see that titer going down as the level of bacteria in the bloodstream goes down. So there is a reason for using them. But again, they do have downsides. It's not specific. Other things can then trigger this test to be reactive. Then let's talk about the treponemal test. These are more specific tests where they're testing for the actual antibody that is developed in reaction to the treponema pallidum bacteria. So you have the actual bacteria that's creating that antibody. You're looking for that antibody. And so you have a lot less false positives with that test. But it's a qualitative. It just says yes or no. So it doesn't give you a titer to see how your treatment is working, or if they've ever had a positive in the past, you're going to have that antibody there, usually for life. Well, I want to give you a scenario that helped me understand this a little better. Imagine a goldfish bowl. And in that goldfish bowl, you have beautiful goldfish just a swimming in the water. And then you take bleach and you pour that into the water. What happens to the goldfish? Yeah, you're right. They die. They turn upside down and they die. Are the goldfish still in the water? Somebody in the chat say yes or no. Are the goldfish still in the water? Yes. The DNA, so to speak, is still in the water. They're dead, but they're still there. And so that I want you to imagine the bloodstream being the water, the goldfish being the syphilis. You pour the penicillin to it, whoop, they start floating upside down, but the DNA or the antibodies are still in the bloodstream. That's why if they've ever had syphilis in the past, you can't use the qualitative treponemal test to see if they have a new infection. It's always going to show those antibodies. I hope that helps a little bit. But the reason why we use this is it's sensitive and it's more specific. It detects more cases, and it also can be used for screening and confirmation in one algorithm. I'm going to show you what the algorithm is in just a second. So what is the ChemBios HIV syphilis rapid test that you're going to be getting in all of your clinics? It is a treponemal specific test. So that's why it also tests for HIV, which is a third generation HIV test, and it's also the treponemal specific syphilis test together. It uses a finger stick whole blood. We're going to learn about it right after this, so I don't want to spend a lot of time with it. Whenever you bill for this test, you use both CPT codes, for one for HIV and for syphilis. So it's 1 drop of test, 1 drop of blood, and you bill for 2 tests. And you get 2 test results. The syphilis health check is also a treponemal test, looking at that specific antibody. This one's been around for about 10 years. The dual test was just authorized by the FDA, I think about a year ago, if I'm not mistaken. This is a 2-step process. You just put a drop of blood in there and you get the results in 10 minutes. But again, it should only be used on those patients who've never had syphilis in the past. Because if they've ever had it in the past, it's always going to show positive. Any questions with the difference between treponemal and non-treponemal testing? Okay. If so, put it in the chat and we'll keep on going. And yes, I will be sending these slides out and you'll have access to the recording as well. All right, traditional screening. We call it traditional because this is the way we screened for syphilis for quite a while. This is the way most people were told to screen for syphilis. And you start by using an RPR or VDRL that you send off to the lab. And then if it's reactive, that's when it triggers the confirmation test. It detects, again, the IgM and IgG antibodies of the lipodal antigen, so it's really not specific like the treponemal test is. And about 80% right now of labs use this algorithm, so it's still very, very popular. There's pros and there's cons to using this. The pros is it's more cost effective if you are in a low prevalence setting. However, all of you on this call are in pretty high prevalence settings. It detects active syphilis and it's used to measure the drug response. So after you give the penicillin, it's used to monitor if you've had a 4-fold decrease in that titer, which is consistent with adequate treatment. The cons is, as we all have seen, we have all encountered a high turnover in our clinics and in our labs. So it requires that person to stand there and do the repeated pipetting to see what is the titer. It does have decreased sensitivity in primary and secondary, primary and latent syphilis. And then the treponemal test is also needed for confirmation. And you have more false positive results with the RPR and VDRL. Here's the traditional algorithm that we use for syphilis screening, and this is also encased in your box resources. So we start off with the RPR. If it is reactive, it dominoes into the treponemal specific, be it EIA, CIA, TPA, whatever. If that is reactive, then you have 2 that agree, and it's either syphilis or previously treated syphilis. If you have a reactive and then a non-reactive, then actually what happens is you have another type of TPPA or treponemal test that will then come in as the tiebreaker. So that is the traditional. For reverse, you're screening with the specific treponemal, well, the one that's looking at those antibodies first. And then if it's reactive, it's going to trigger the RPR so that you can, or VDRL, that you can titer out how much bacteria is in the bloodstream. 20% of labs use the reverse screening algorithm. This is traditionally done whenever you live in an area that it has a high prevalence because it is more specific. Um, it's automated, it's fast. Especially when you're doing a lot of these tests, you do want to use the reverse screening. There's less lab to lab variation, and it nearly eliminates biological false positives. If it senses that um, the antibody, then either they had syphilis in the past or they haven't. Now, the cons is it only is going to tell you either a yes or no answer or a reactive or non-reactive. It's not going to allow you to have that level of infection in the bloodstream that you can then monitor for adequate treatment. So here is the reverse algorithm for syphilis. It's going to be treponemal first, and if it's reactive, it then dominoes into the VDRL or RPR. If it's reactive, then you have two that agree, and you either have syphilis, now syphilis or untreated syphilis or have had it in the past. But if you have one that's reactive and then you get non-reactive, it's almost like mama's saying yes and daddy's saying no. Then what does the 2-year-old do? They go to grandma. So what does grandma say? You're going to do another second treponemal test. And then it's going to break that tiebreaker. Either you're going to get a reactive second treponemal or you're going to get a non-reactive second treponemal. This is a very busy slide, but the reason why I like it is let's follow if we were to use the reverse screening algorithm, which is the screen line. Within 2.5 weeks, it starts going up to where it's positive, and you can see that it's usually positive for life. Okay. If you do the if you do the traditional screening where you're doing just the VDRL or RPR as a first test, watch what happens to the VDRL and RPR. About 3 weeks, it starts to go up. And then whether if it's treated, that's great. It almost goes down to non-reactive or a low titer. But even if it's not treated, do y'all see how some patients, about 40% of patients who've never been treated are going to be missed because it's gone back to non-reactive, and you're missing all of these patients that were never treated. So that's why a lot of our clinics have moved more to the reverse algorithm so that they pick these patients up that have had syphilis for usually longer than a year, but were never treated. Y'all probably all heard the saying, if it looks like a duck, it probably is a duck. Well, that is very true in primary syphilis. If you will see something that looks like a chancre, it may still be, but the test could just not be reactive yet. In 60 to 80% of the cases, if they have a primary syphilis or a sore, then the VDRL and RPR is going to be positive. But in 20 to 40% of the cases, it may be still negative because it hasn't had a chance to trigger yet. It might be in that early window period before you see it. Similarly, in 100%, if you see a rash and that RPR is negative, it's not syphilis because that's a wide dissemination and it's going to pick it up 100% of the time. Both tests will if you have a rash. Now, if you have no symptoms and they may have had this infection for a while, you can see that 10 to 60 to 40% may be missed if you use just the RPR or VDRL as your primary screen. Now, looking at the specific test, you still have that window period in the very beginning. It takes time for that antibody to be created in the bloodstream and then also be detected by the test. So you still have to do the duck theory. If it looks like a duck, treat it like a duck. 100% of the time, it's going to be positive if they have the secondary symptoms. And you can see the big difference is really in the latent stage. Only 5% of the time does this ever go back down to non-reactive. So you're going to pick up a lot more in that latent stage by screening with the treponemal specific. This is just an interpretation diagram that if you get that positive and then this is negative, it's going to trigger a different treponemal test. And if that second, this is the grandmother analogy, if the grandmother says it's positive, then either there's a prior history of syphilis and you need to do a record search to see if they were ever treated. And then if it's negative, then no further evaluation or treatment necessary if you've got two that are agreeing on. Any questions before we get into titers? We're almost at time for a break, but I do want to go through titers real quick. If there is any questions, reminder, put it in the chat. I've got it up, so I'm looking at it so I can answer your questions as we go. A titer is a concentration of a substance in a solution. In other words, it's almost like saying how many goldfish are in the water. You know, what is our concentration of syphilis in the bloodstream? So go back to where I showed you how the RPR is done, where you take the drop of blood in the first wheel and then you move to the second. Well, eventually it's going to become so diluted that it's not going to clump anymore. So that's what the titer is showing. At what point is the syphilis bacteria so diluted that you don't really see it anymore? So the higher the titer, the more bacteria that's present in the bloodstream. Okay, our goal is to have a fourfold decrease. The way that the titers work is you multiply this by 2 for every dilution. So 1 times 2 is 2, 2 times 2 is 4, 4 times 2 is 8, and it keeps going. And I've seen titers up into the thousands. Excuse me. You can take whatever titer that you have and divide it by 4. So 32 divided by 4 is 8. So you want to see a fourfold decrease within a year. If you don't see that decrease, then you have to think about, well, does this patient have any signs of neurosyphilis? Or have they been re-exposed? If you see it going up by fourfold, then that is a clinical significant finding, which says that they've usually been re-exposed to syphilis and we need to retreat. So I also think about this in the line of decimal points. So if you were to like print this out and laminate it, you can move this over 2 decimal points and you want to see it go down to 1 to 8 or less within a year. But if it starts going up, then you know that you've got a problem. This is kind of what I said already. A fourfold change or 2 dilutions is clinically significant. And you want to make sure, we all have patients where they come in and we do the test and it takes a while to come back. And then we need to treat. Well, it might have been 2 weeks between the time that we originally drew the blood and the time that they come in for treatment. You want to go ahead and draw a test at the time of treatment so that we have an accurate, every day that they're not treated, more treponema pallidum is building up inside that bloodstream. So 2 weeks ago, it could have been a 1 to 8, but now it might be a 1 to 16 by the time we get them in for treatment. So make sure that you draw that. If it's been over 2 weeks from the time the original one, you want to go ahead and draw another RPR just to get a valid one at time of treatment. Monitoring the success of treatment. We are going to re-titer our patients depending on the frequency depends on if they have HIV or not. If they're a person living with HIV, we are going to repeat those titers more often because they're more susceptible to neurologic involvement. And we want to also make sure they're not having any headaches or visual problems or ear problems. For those who are not living with HIV, we're going to retiter them at 6 and 12 months. And usually by 12, we can see the fourfold decrease that we want to see. If you start seeing that they're not going down by a year, then we need to consult your physician that's in their office or infectious disease and just make sure that, they don't need a spinal tap to rule out neurologic syphilis. If they start going up, then we know they were reinfected. So make sure we retreat them and get their partners treated as well. There is some patients, probably 10 to 15%, that as you're monitoring the titers, these patients will never go down to non-reactive. They'll stay at like a very low titer, 1 to 1 or 1 to 2. It's just right above where you could say non-reactive. So those patients are called serofast. That's not a bad thing. Some people are just like that where they just don't go back down to non-reactive. The main thing we're checking for is, did they have a fourfold decrease after treatment? And if they did, we're good to go. Let's do an example together just so I can show you how these titers work. Remember, you always have to have 2 labs saying yes. So here we have a troponemal screen that says reactive, and you have a VDRL that's 1 to 256. So right here. And then 6 months later, you're going to redraw the blood. Of course, it's still going to be a reactive CIA. You can just do the VDRL. You do not have to do the CIA again because we know we're dealing with syphilis. So the titer's gone down to 1 to 8. I'm gonna ask you to put this in the chat. Was this treatment that we gave successful based on these titers? It was 256. Did we have a fourfold decrease? Excellent. Yes, we did. Many patients, successful treatment, absolutely. Many providers would look at 1 to 8 and say, oh, but it's still so high, we need to retreat again. Do we need to retreat again? Yes or no in the chat? No. This was a successful treatment. And just because we want them to get down to non-reactive really quickly, we do know that it can take some time. It can take up to a year and sometimes even longer. But if they have had that fourfold decrease, then we're good to go. If signs and symptoms persist or recur, or a fourfold increase persists for greater than 2 weeks, we need to be thinking about, have they been reinfected or have they experienced a treatment failure? Think of reinfection if there is no neurologic symptoms, they've continued to be sexually active, then we want to go ahead and retreat. But let's say they have not been sexually active, or they have some type of symptom of headache or eye visual changes or ear changes. We need to do a lumbar puncture. Well, not we. We need to refer them for a lumbar puncture so that we can rule out syphilis in the spinal column and the CSF. If they have syphilis that has invaded the central nervous system, bicillin will not work. You have to use IV penicillin in order for it to cross that neuro barrier there. And always screen for reinfection for HIV. All right, everybody. I think we need to take just a mental break for about 5 minutes, collect ourselves, and we're going to go through treatment and we're going to work on some case studies. I will see you back in 5 minutes. And if they're pregnant, oh, again, if they're pregnant, the only option is to get them desensitized with penicillin. This is a beautiful chart of treatment with syphilis by penicillin stage, whether it be primary, secondary, or early, it's all the same treatment. Late, latent, and unknown duration, we have a series of 3, 1 week apart. And then neuro, ocular, and otic, all I need to remember is it's IV and it's a referral to my infectious disease doc so that they can get them treated. During this penicillin shortage, there has been a shortage, as you know. Um, from what I'm understanding for hearing from the National Syphilis Task Force is that the penicillin shortage is much better and you should have that availability to get penicillin on your shelf through 340B. If you do have any issues though, you can use Exicillin, which is originally from France that has been FDA approved to be used in the United States. And also you can use doxycycline if you cannot get the penicillin and they're not pregnant. There's something called a Harris-Herxheimer reaction that can happen. And this is a acute febrile reaction after you give the penicillin, and they can get headaches and muscle aches and fever. It's not an allergy to the penicillin. It is a result of the treponema pallidum in the bloodstream dying off at such a high rate. It gives off a toxin, and that toxin in the bloodstream is what they're actually feeling. So patients, they need to be informed that if they don't feel well, in the next 24 to 48 hours, it could be this reaction and drink lots of fluids. If they are pregnant and they start having the reaction or contractions, then they should get with their OBGYN just to make sure that they don't need additional support while these treponema pallidum are dying off. For a lumbar puncture, check with your medical director. Everybody's a little different. In our case, in Louisiana, we used to refer to infectious disease. They're the ones that would admit them to the ER and do the spinal tap. But it could be different. It could be a neurologist, it could be an infectious disease doc, but whoever has the ability to get them in the ER or their office and do a spinal tap to rule out neurological involvement. Good question. And that leads us right into neurosyphilis, so great timing. It can occur at any stage of syphilis. They don't have to have it for years. They could have it for a couple weeks and it just invade right on in. Always screen for HIV infection as well if they do have any neurological involvement, because with HIV being immunocompromised, it has a likelier chance of becoming into neurosyphilis. So, signs and symptoms may include subcognitive dysfunction, motor or sensory deficits, especially with the eyes or the ears, cranial nerve palsies. It could mimic Bell's palsy, and signs and symptoms of meningitis or stroke. Make sure you do a CSF exam before treatment, and if there's any signs of neurological involvement, the IM penicillin in the hip is not going to work for them. We need to get them with the proper provider that can diagnose and treat through the IV. Let's see. I think we already talked about all of this, but the treatment for any eye or ocular or otosyphilis is IV penicillin for 10 to 14 days, if that is found. And I want to tell you a story about what happened. I'm going to tell you in just a minute. I think there's a case study on it. Person with clinical signs and symptoms consistent with ocular disease, they could have uveitis, panuveitis, interstitial keratitis, diminished visual acuity, blindness. So this is a emergency that if they have any kind of eye or ear issues, get them immediately seen because they can lose their sight or their hearing because of the damage that the bacteria is doing. Yes, here is my case study. Okay, hope you didn't see that. Here's the case study. A 32-year-old MSM referred to the clinic for treatment of positive syphilis serology. When we did his serology, he had an EIA of reactive and RPR 1 to 256. Now we're going to do this together because I want you to see where my brain goes when I'm doing the puzzle. Do we have two tests that agree this is syphilis? Right here, there's reactive, and right here is an RPR that's positive. So yes or no in the chat. Do we have two that agree? Yes, that's correct. Yes, we have reactive and RPR. So we know we're dealing with syphilis in some form or fashion. So the patient comes in and he was wearing dark sunglasses. He had pain in his right eye with photophobia. And when we asked him to remove his sunglasses, we thought he was just being cool. When we asked him to remove his sunglasses, he said, "I can't. My eye is hurting so bad." And then when we looked at his right pupil, we found that it was non-reactive to light. So what would be the correct thing that we would do? Yes, it's syphilis. Would we give the bacillin and have him return in a week? Would we call infectious disease for a consult or send him to the ER for evaluation of ocular syphilis and IV penicillin? Perfect. Y'all are getting it. Yes. So yes, this is definitely syphilis. We answered that together. And yes, we want to send to the ER or emergent management. If we just order a consult, there's no telling how long that's going to take to actually be done and go through. This is an emergent situation, so send them in for immediate treatment. Excellent. So syphilis among persons with HIV, as I mentioned, HIV being immunocompromised, the infection can disseminate very fast. You can get very high titers in a person living with HIV. So, and you can get conversion into neurosyphilis as well. So make sure that you're testing for HIV at the same time as syphilis. Follow up for those with primary and secondary syphilis when they're treated and they have syphilis is going to be much more often. It's 3, 6, 9, 12, and 24 months after therapy to make sure that that titer is going down fourfold instead of staying the same or even going up. If any of these happen, if the titer does not start to go down or is sustained for over 2 weeks, or if there's a fourfold greater increase in titer, we need to consult infectious disease for further guidance. True or false? Persons living with HIV must have titers monitored more frequently due to the possibility of treatment failure and neurological involvement. True or false? So the correct answer is true. Persons living with HIV must have their titers monitored at 3, 6, 9, 12, and 24 months. Whereas a person that does not have HIV, they would have it done just at 6 and 12 months. Let's talk a little bit about pregnancy. Rec- most, I can't say most, many states have laws now that state that if you care for a person who is pregnant, they need syphilis screening at the first prenatal visit, around the beginning of the third trimester, and at delivery, or any other time risk factors are identified. What we're doing in this pilot project is we're adding one to that. We're doing it at any time a UPT is done, whether that be positive or negative. So that is this pilot is to try to get on the upswing before a patient gets pregnant or at the positive UPT to make sure that we treat them as soon as possible, or ideally before they get pregnant. Penicillin is the only treatment option in pregnancy. So therefore, if a patient is allergic to penicillin, what we have to do is consult either an allergist or an infectious disease doc. They put them into the ER. They give them steroids and Benadryl and all kinds of things. They have a crash cart standing nearby, and they give them the penicillin anyway, because that is the only thing that crosses that placental barrier. There's also, if they are late, latent, or unknown stage, you have to give 3 doses. Because you have to have that medication stay at a certain level in order to treat the mother and the fetus, you have to have the doses between 6 and 9 days apart. If they're 10 days between doses, you have to restart the series. It's very important that they stay within that 6 to 9 day window of opportunity. Screening for syphilis is recommended at the following intervals in pregnancy. Choose all that apply. Yay! Yes. The answer is all the above. Thank you. Very good. Very good. All right. Not sure why it's showing my answers. Okay, here's a case study. A 22-year-old comes in with a positive UPT in the clinic. She was treated for secondary syphilis 2 years ago with bicillin ×1. All right, the first thing I'll look at is she has a history of syphilis. So was the last syphilis treated appropriately? For secondary syphilis, is the appropriate treatment 1 dose of bicillin? Just put yes or no in the chat. Secondary, 1 dose. Correct. That is the adequate treatment. She was adequately treated. And then her labs 2 years ago was RPR. Oh, she had reactive and an RPR of 1 to 32. Is this syphilis? We have 2 that agree, right? Now, here's the puzzle. Today's lab results is reactive, non-reactive. So we have discordant results. And then we have a third that pops in. That's the grandma tiebreaker. Reactive, reactive. So we know it's syphilis. Now, did we have a 4-fold decrease right here? So what do we do? Is this syphilis? Is it a biologic false positive? Do we need to give 1 dose, 3 doses, or no treatment adequately treated in the past? What do y'all think? Y'all are getting it. That's correct. So no treatment is needed. This was adequately treated in the past. However, if we didn't know this past history of what the labs were 2 years ago, we would not be able to say that they were adequately treated, because we've got to have this original lab to make sure we have that 4-fold decrease. And that's where your local health department is going to come in. Whenever you get these results and you don't have that past history, you notify your local health department and they get you that last history so that then you can stage and manage appropriately. So yeah, no further treatment is needed. Let's say a 24-year-old with a positive UPT in clinic and syphilis point of care is reactive. First of all, for the purposes of our pilot, if you get a positive UPT and you get a positive point of care test, what are we going to do? Do we give the bacillin today or no treatment? Did y'all see there's the joining instructions if you need it. Yes, because in areas that have a very high rate, it is better to err on the safe side and go ahead and treat than not to treat and then figure out. So if she says that she does not have a history of syphilis, and we do the point of care test and it comes up reactive, we are going to go ahead and give that bacillin that same day. If she said she had a history of syphilis, we're not going to do the point of care test because that's only for people who have never had syphilis in the past. Does that help? Okay. Let's do this one. What if the pregnant person is allergic to penicillin? What are we going to do? Do we refer to IID or an allergist for desensitization and penicillin administration? Do we treat with doxycycline or give doxycycline after she delivers? That's correct. We are going to go ahead and refer to ID and get her treated ASAP. Doxycycline is contraindicated in pregnancy, and we're certainly not going to wait till after delivery to give any treatment because the fetus needs to be treated as well. Good deal. Here's a 22-year-old pregnant person at 10 weeks gestation. Her labs 1 week ago were reactive and 1-to-1. So first of all, let's talk about this. Is this syphilis? Do we have two that is agreeing? Reactive, 1-to-1. Is this syphilis? Yes, because we've got two. DIS is reporting treated for secondary syphilis in 2020 with 1 dose of bacillin. So is this the correct treatment? 1 dose for secondary? Yes. All right, so now let's look at our labs. Right now, it's 1-to-1. It was 1-to-64. Has there been a 4-fold decrease? Yes. So now this is what we call patient is serofast. It has a low titer. Probably will always have a low titer, and that's fine. No further treatment is needed. Great job. Great job. Okay, why is staging so important? Well, if you don't get the correct stage, if you misidentify it and put it as early instead of late, then you're only going to give 1 injection when you should have given 3. So very different stages. Let's talk about staging this one. I'm going to ask you to do this one on your own. 20-year-old male assigned at birth comes into clinic with a rash on the bottom of his feet that began a week ago. He was exposed to syphilis about 3 months ago. So if you see the rash, what stage are we talking about? Excellent. Secondary, because that infection has gone widespread and you get more of those type of symptoms all over the body. Excellent. All right, here's some more staging. Continued. what is the treatment for secondary syphilis? Do we give 1, 3, and then choose all that apply? Do we give, if it's a male, 14 days or 28 days of doxy if we don't have penicillin? Excellent. Yes, this is the appropriate treatment for primary. 1 dose or doxycycline twice a day for 14 days. Perfect. So a 32-year-old female comes in to clinic for a wellness visit and a refill on their contraception. And whenever you do the exam, she doesn't have any symptoms of syphilis. But because a pregnancy test was done, we went ahead and did a point of care test as well. And it comes up that the point of care test is reactive. She does not have a history of syphilis. And what are we going to do with this reactive? Are we going to treat same day or not treat same day? I don't think I have that option. We are going to treat the same day. Always treat the same day if you get the reactive point of care. Now, when we get the DIS report back, she had a syphilis lab in 2000 that was not reactive. Is that between the 1 year time frame? 2000 or to 2024? Are we within 1 year? Yes or no in the chat? Correct. So in that case, is it early or is it late? It's late. That's correct. So the answer to this would be yes, it's syphilis. Yes, it's syphilis. It is late latent. And the treatment would be bacillin 3 doses. Yes, it's syphilis, late latent, bacillin 3 doses. And then because her RPR is non-reactive, there would be no follow-up indicated because you can't go down fourfold from non-reactive. There's nowhere to go. So you don't have to do any follow-up after that. All right, I'm going to ask y'all to do this one. 30-year-old comes into this clinic for STI screening. New sexual partner with inconsistent condom use and her syphilis point of care test is reactive. We find out that the DIS report that the patient had a negative treponemal screen 9 months ago. So now are we within that window of 1 year? And then based on that, how would we classify it? So y'all go ahead and put in your answers and let's see where we are. Is this syphilis? What is the stage? What is the treatment? And what is the follow-up? And then when the lab comes back, because we're always going to send lab with a positive point of care test. Reactive, non-reactive, reactive. You're getting it. Yes. This is syphilis. Yes. Now, it can't be primary unless we have a chancre. And she's asymptomatic. So we know it's not that. And she had a test 9 months ago, which is within that 1 year time frame. So early latent. She's going to get 1 dose of bacillin for early latent. And depending on her titer is when we're going to follow up in her HIV status. So or titer is non-reactive, so no follow-up would be needed. Is that making sense? So as far as the follow-up, you want to see a fourfold decrease, but if you're already at non-reactive, there's nowhere to go less than non-reactive. So you don't have to monitor your treatment because you can't monitor anything in the negatives. All right, let's do this one. 32-year-old male with a painless penile ulcer. Syphilis point of care testing is reactive, and he is HIV negative. We sent off his lab for confirmation, gave him the bacillin the same day, and this is his labs when it returns. So is it syphilis? What stage? What treatment? And what follow-up? He got bacillin the same day. Excellent. The only thing is he would have no further treatment required because we already gave him the one dose, which is needed for primary syphilis. So yes, it's syphilis. It's primary. No further treatment required. And yes, we're going to schedule the titer in 6 months. Excellent. Here's a 49-year-old for routine screening, history of syphilis in 2000, with an RPR of 1 to 16. He was treated appropriately for primary syphilis with just one dose. Is this person a candidate for point of care testing if he had a history of syphilis? You're correct. No is the answer, because remember that if they have a history of syphilis, it's still going to show that antibody in that bloodstream, even though it's an old infection. So the point of care test isn't going to do us any good. So you have to send an RPR off for that. All right. So 3 months ago, the labs were reactive, uh, negative, and reactive. So is this syphilis that we're dealing with? Do we have two that agree? Yes, we have two that agree. So we know we're dealing with syphilis in some form or fashion. And then we look at how much syphilis is in the blood. 3 months ago, it was negative, but now it's 1 to 4. Is this a fourfold increase? Yes. Because it's a fourfold increase, we now have a new infection, and now you see what it would look like if we have the new infection and we need to retreat. Great. All right. 27-year-old comes in with urethral discharge, treated for gonorrhea, chlamydia, no history of syphilis in the past. Is this patient a candidate for point of care testing? Yes, absolutely. Great job. You know why? Because these tests you can use on anyone. The minimum that you have to use them on are persons who are getting a pregnancy test. But you can use it in men, you can use it in anyone. Very good. And because they don't have a history of syphilis in the past. So we did the point of care test and it was reactive. We sent off the blood for confirmation. It comes back reactive, negative, reactive. Is this syphilis? Do we have two that are agreeing? So yes, this is syphilis. Last test was 2 years ago at non-reactive. Is that within that 1 year window? If not, we have to stage it late, which means that there are 3 doses and there's no titer to follow. Are y'all following? Put it in the chat if all this is starting to make sense. Yes, it's syphilis, late latent, 3, and no follow-up. Great. I know we are running out of time. I want to make sure that, okay. Here's STI testing because he has a new sexual partner. Point of care is reactive. HIV is negative. So it comes back reactive and 1 to 8. So right there, we have 2 tests that are agreeing it's syphilis. So we know it's syphilis in some form or fashion. DIS doesn't have any history on it. So now we're dealing with, yes, it's syphilis of unknown duration, because we don't have any labs that show if it's within that year or over. We have nothing to go on. So syphilis of unknown duration, which automatically falls into the 3 doses. And then to determine when we're going to have them come back, we look at the titer. We do have a titer, and he's HIV negative. So we're going to have him come back in 6 months. Here is a rash on the abdomen, back, palms, and soles. Point of care is reactive. HIV is negative. So we're going to give the bicillin today. We're going to send off the labs. And when the labs come back, it says reactive 1 to 128. Is this syphilis? Yes or no? Yes. Yes, it's syphilis. What stage are we dealing with? We know that primary is the sore, secondary is the rash, so secondary. For secondary, is it 1 shot or is it 3 shots? 1 shot. And then we look at the titer. What is the titer today? 128. He's HIV negative. We're going to see him back in 6 months. Excellent. Very good. All right. 17-year-old comes in, has a reactive RPR, and was told she has syphilis. Syphilis lab confirmation returns EIA non-reactive. So her point of care test, or her, the lab send-off was non-reactive. Is this syphilis? No, that's correct. It's a biologic false positive. And you're going to get a lot of these that come in from like the blood bank or from another, maybe physician's office that just had the 1 test, but didn't have both tests. And remember, it takes 2 to confirm that they have actual symptoms. So real quickly, I wanted to go through the pilot workflow of what we're going to be doing in the clinics as we move forward. You can do this for any patient. You can use these tests for any patient, but the minimum that you have to do is when you perform a pregnancy test, whether it's positive or negative, it doesn't matter. You're going to ask the patient if they have a history of syphilis. If they do, you're going to send off blood to the lab for syphilis testing. If you wanted to use reverse screening algorithm, that's fine. If you want to use the traditional, that's fine. Whatever your medical directors wish to do in your clinical setting. If they do not have a history of syphilis, then you're going to perform the point of care test. And then depending on the result, if it's invalid, you can either do another point of care test or you can send off the blood to the lab. If it's non-reactive, yay, you're just going to ask just to see, is there any reason you may have had a exposure in the last 3 weeks? Do you have a new sex partner? Did your sex partner say they had syphilis? Anything like that. Um, if no, then no further testing is required. If yes, then you're going to send the blood off if they did have an exposure, stage and treat. Reactive, definitely treat same day with the bicillin or doxycycline, whatever you have in your clinic, and send blood for testing.